Hotbed Talk.
Our next presenter is going to be Tim Miller, who's been up here before. Tim is from Duke University, and he's going to be talking about perioperative blood pressure and really about POQI 3, the different POQI papers that have been coming out recently. So welcome, Tim, please.
Thank you, Desiree. Thank you very much, Desiree. It's a pleasure to be here. So I'm going to speak a little bit about POQI in general, and then particularly highlighting POQI 3. So I have some disclosures, do some consultancy work for Edwards. There's also the national PI for a study in the States on assisted fluid management, so the use of decision support tools to aid fluid management. That study is finished. We have the results, and I can't share them with you, but we will be sharing them at the ASA if you are interested. And I've also been very involved with the American Society for Enhanced Recovery, now the president, and POQI since the beginning, being a board member and being involved either directly or with other chairs in organising all 6 POQI consensus conferences. So this is the POQI website. So POQI's been going now for about 3 years. This website's available for all of you to log on and to be able to download the POQI articles. And importantly, all of the infographics that are used in the POQI articles are owned by POQI. So they're freely available for you to download, for you to use in other manuscripts with permission of POQI. And that's one of the very important things that we wanted from POQI, to have manuscripts and infographics that are accessible to all. So you'll know a lot of the people that have been involved in POQI, Mike and Monty, Andy Shaw, who's speaking later, TJ Gann. And what POQI is really is an international multidisciplinary group that aim to organise conferences related to topics of interest. So if we look at the POQI consensus conferences, there have been 6 which have occurred so far. 4 have been published and 2 are in the works. And if you look at these conferences, they aim to really analyse and look at all the literature, but also, importantly, to get experts. And I'm sorry for any of you who haven't been invited, but for each conference, we invite alleged experts to come in. And the conference generally will handle 3 or 4 topics, and each topic will have a chair. And in that group, they will propose some consensus statements around their topic. And then they will come into the plenary session, present these statements to the group at large, get challenged, get voted down, very similar to the debates that you've seen here. Then they'll go back to their small groups, refine, and we go back and forth 3 or 4 times until we have agreement on the consensus conference statements. And if there is not agreement, then we'll specifically state that within the manuscript. Importantly, we will also say when there are limitations in the data, and we will also get off the fence. So this is expert opinion as well as a literature review. And that's important because we don't want to say there's insufficient evidence to make a recommendation. You will see that sometimes in a Cochrane review, whereas we're getting experts together, and at the end of the day, we want to make a recommendation because we're all having to look after patients tomorrow, and we're all having to make changes in decisions in clinical practice. So we want to make recommendations that are going to be useful for the average clinician. So POQI 3 occurred a couple of years ago around the time of this conference, looking at perioperative blood pressure. So 4 groups: the physiology of blood pressure, which was led by Gareth Ackland; preoperative blood pressure, particularly looking at how we manage pressure preoperatively, led by Rob Sanders. Intraoperative blood pressure group was led by Dan Sessler, who's done a lot of the work in this area. And then perhaps the hardest task was the post-operative group, which was led by Matt McAvoy from Vanderbilt. And these articles have been recently published in the BJA in May of this year. All 4 articles were in this the May edition, with this cover art, which was Michael Pinsky drew this diagram literally on the back of an envelope, I think, looking at the relationship between flow and perfusion. So why did we choose to do perioperative hypotension? Obviously, it's quite topical. But if you look, one of the reasons that I think it's very interesting is the data on it, at least until a few years ago, was very sparse. There's no single accepted definition for intraoperative hypotension. I mean, 10 years ago, this is quite damning. 130 articles, 140 definitions. I mean, that really is a damning indictment on our community. And even the commonest definitions, 20% systolic decrease from baseline or a systolic blood pressure less than 80, you can see 12 and 7% of the time those were the definitions that were used. So incredibly diverse group of definitions. However, if you use those two commonest definitions, same manuscript, 15,000 patients, you can see that 93% of patients had this BP decrease greater than 20% from baseline, and 41% had a systolic less than 80. And I think, all of us would agree that hypotension is common. Why, when we've been practicing anesthesia for so many years, have we really not got good data till relatively recently about the incidence of hypotension? I think, a lot of this data we've really been able to get from electronic medical records. It's big data, and since the era of big data has started, we've really been able to finally get a handle on hypotension and perhaps some of the harm that it may cause. So the first group I'm going to talk about, the preoperative blood pressure group, as I say, led by Rob Sanders. One of the things they really wanted to get into, and we spent quite a long time debating this, was how do you define baseline? Because we know that your pre-induction blood pressure, not surprisingly, is higher than it is during the preoperative evaluation, typically by about 10 to 12 millimeters of mercury. So the first consensus statement they came out with was preoperative blood pressure values may be used to define targets for perioperative blood pressure management. However, these should ideally reflect the patient's usual preoperative blood pressure. Maybe not surprising, but the gold standard for doing this is 24-hour ambulatory blood pressure. So if you have that, if that's been done by the general practitioner, then that is the method that you should use. My brother's actually a GP in Bristol, and I was surprised chatting with him about this, how commonly now this is done to determine your normal blood pressure. If you can't do this, then you should try and look for a preoperative clinic blood pressure. At Duke, we have Epic. If any of you use Epic or any other electronic medical record, you can look in that data. We can look in the graphs function in Epic, and we can see every blood pressure that has been taken on that patient over the preceding 5-10 years. So we're able to get a very accurate baseline. Next consensus statement, although extremes of blood pressure may be associated with increased risk, there is insufficient evidence to recommend a specific threshold of blood pressure upon which to decide whether or not to proceed with surgery, unless the extreme blood pressure is associated with a medical emergency. Again, important, and interestingly, there's recent data been published in the last month or two that's showing that maybe preoperative hypotension is actually associated with more risk than preoperative hypertension. Next statement, there is insufficient evidence to support lowering blood pressure in the immediate preoperative period to reduce perioperative risk. I think an important statement to put in there, I still see this occur occasionally, that someone will come in with preoperative hypertension and they'll be given labetalol or some other drug in the sort of preoperative area. It always seems to me to be a strange practice. One thing that we know that anesthesia can do is lower your blood pressure. I don't think we need to do additional help in the preoperative period. Hence, we put this statement in. So moving on to intraoperative blood pressure, say this group led by Dan Sessler, who's, as many of you will know, has done a lot of the work in this area from the database at the Cleveland Clinic. In fact, pretty much 90% of the data in this area comes from the Cleveland Clinic, which is probably one of the criticisms of the data. So does intraoperative hypotension matter? So this is perhaps the most famous study from the Cleveland Clinic, looking at nearly 60,000 patients. All this data from their database is obviously retrospective, and it's obviously just looking at associations, not causation, which we can come on to. And particularly they looked at the relationship between lowest blood pressure and myocardial injury, or MINS, that we just talked about, as well as an important outcome, which is AKI. And if we look at the data, you can see there is a clear association between MINS and AKI and hypotension. And importantly, even small durations of hypotension were associated with adverse outcomes. So you can see 1, 3, 5, 10 minutes of hypotension, and this is defined as a MAP less than 65, associated with both MINS and AKI. And if you'll notice, this is a logarithmic scale, so there really is a fairly pronounced inflection point. Importantly as well, 30% of these hypotensive episodes were between induction of anesthesia and incision. So they weren't related to blood loss, they weren't necessarily related to anything the surgeon's done, that is anesthesia causing hypotension. If you look at this a slightly different way, looking at the reduction from baseline of MAP by 20%, again you can see very similar curves, similar inflection point for both MINS and AKI. So the conclusion was that an absolute threshold of around 65 or 70, or the relative threshold, were both related to myocardial injury and AKI, and at any given threshold, the duration of exposure increased the odds. Another study came out more recently. This was from Tom Abbott, with a secondary analysis of the VISION database. Their thresholds were looking at a systolic blood pressure less than 100, and also looking at heart rate, particularly heart rate greater than 100. A little bit of a busy diagram, but if you focus on the sort of tachycardia on the top line and the hypotension on the bottom line, you can see that tachycardia was associated with MINS, myocardial infarction, and mortality, and hypotension was associated with MINS and mortality and not quite statistically significant for myocardial infarction. And that moves us on to the only randomized controlled trial. We've already mentioned it, the IMPRESS study, just to go a little bit more detail. And I think further trials are in the works. It's amazing this trial got into JAMA despite the fact that it only had 298 patients. So they randomized patients to either keeping their blood pressure within 10% of baseline using peripheral norepinephrine infusion, or the routine care group used ephedrine to keep the systolic greater than 80. And I think that's important to look at the two groups. The other thing that is very important to say in this study is that all patients got goal-directed therapy, and all patients had at least 2 fluid boluses before they started the norepinephrine infusion. And I think that's a very important point to note, because yes, they saw an improvement in outcomes in the norepinephrine group, but they were fluid optimized before they were squeezed. And I think one of the potential unintended consequences of this literature is a lot more use of vasopressors, potentially in patients who are hypovolemic, and I'm sure we'll come on to that in the discussion. So this was our consensus statement: intraoperative mean arterial blood pressure below 60 to 70. Originally we just put 65, but the reviewers, because there's a little bit of variation in the literature, wanted that changed, are associated with myocardial injury, acute kidney injury and death, and systolic arterial pressures below 100 are associated with myocardial injury and death. And again, injuries are a function of hypotension, severity and duration. Importantly, we did a little caveat at the bottom saying that although the data is not granular enough to say this, for patients with preoperative hypertension, the threshold at which harm occurs may be higher. And we did put a little statement in about potential unintended consequences that I've mentioned already. And we said there are at least strong theoretical concerns about using pure alpha agonists. As I said, the IMPRESS study used norepinephrine. In practice, a lot of people, I think, use phenylephrine. We definitely do at Duke. We don't use peripheral norepinephrine routinely, which increased blood pressure at the time of at the expense of tissue perfusion. And I know Monty's spent some time in the lab looking at models, and if you really squeeze someone who's hypovolemic and you look at the microcirculation, it can get pretty ugly pretty quickly. And I think, again, that is a potential harm. Other statements that we made for adults having non-cardiac surgery, there is insufficient evidence to recommend a general upper limit of blood pressure at which therapy should be initiated. That's different than for cardiac surgery, at which there is evidence that going above a systolic of 140 is associated with harm. And finally, I think the group that had perhaps the hardest task was led by Matt, because it's largely an evidence-free zone. We know that hypotension post-operatively is common, but very little data looking at it. Dan Sessler and the Cleveland Clinic group are starting to look at this, and they've started to show some associations with harm, but still not that much data. A lot of data does come from early warning scores. So the consensus statements, well, there is evidence of harm associated with post-operative systolic less than 90. However, the level of risk is increased with longer durations of hypotension. And for patients with preoperative hypertension, again, the threshold at which harm occurs may be higher than a systolic of 90. And again, following on, there is insufficient evidence to precisely define the level of post-operative hypertension at which harm will occur, but a greater frequency of post-operative blood pressure measurement is likely to identify risk of harm and clinical deterioration. And I think this is one thing that was debated at length in this group, and they came up with this nice infographic, at least where we are at Duke. Patients, when they go to the ward environment, they very quickly decrease the level of care that they get in terms of nursing ratios, and they fairly frequently go to 1 to 2 hour or 1 to 4 hour blood pressure measurement. And I do think that the hospital of the future, if you're sick enough to be in hospital, you're going to be sick enough to be monitored. And I do think we're going to get more continuous monitoring. And I think that's what a lot of these post-operative patients, that will be the value that they get. We can discuss that a little bit more in the discussion. I know Lee Fleischer at EBPOM a year or two ago spoke about what is the value of post-operative critical care, and it may be a lot of the value just the increased nursing ratios rather than necessarily having pumps, machines, ventilators, etc. So being a little bit more careful with our monitoring and careful with our nursing ratios. And I think patients undergoing major surgery, probably the way of the future will be increased blood pressure monitoring. Thank you very much.
Lee Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.